Best way to start is start at the beginning. And so what we did, and this has been running for a couple of years now, completely unfunded. So this is a bunch of, I guess, energetic, enthusiastic and experienced people who just said enough, let's have a go, let's sort of bring these things together. And we started nationally, focus on Mind the Gap. We called it Navigating Health because, a bit like Sumit had said about definitions, that's what we were all focused on, navigating health. We added a hashtag because it just sort of made it a bit more contemporary, quite frankly. But that was in the age when Twitter was a thing, and Twitter is now X, and clearly maybe that's a little bit different. But what we did is we ran 2 webinars in September 21. Thanks to the help of the Consumer Health Forum and many others. A few people have mentioned Jerry. She's been a co-collaborator of mine for a number of years. I did my MPH with research with her at Peter Mac, and also the Northern. But as we know, the Northern was locked down for a substantial part of COVID. But essentially what we did is we did 2 webinars, 2 weeks apart, and we focused on a patient journey across a lifetime. Now, this was a real high-level view, but the top row there talks, we took an approach of sort of dyads, if you like. So Leanne presented alongside Jane Crow, who's a GP, and they were talking about sort of managing patients through a continuum. Alison and Heather talked about, well, what do you do if you've got a child that's being diagnosed with, or rather is not meeting their development milestones? What then happens? Because then what happens is you encounter the health system, you meet a paediatrician, but you also encounter the disability system and the education system, and none of them talk to each other. And back to, again, Sue's quote on the slide. We then looked at adolescence. So Rob O'Leary presented for Batir around sort of lived experience. Jerry talked about chronic diseases, Keith Stockman from the Northern, and then Andrew Clark talked about care navigators in aged care. And then what we did for the second meeting, we added in complexity, as if this wasn't complex enough. So we talked about the complexity of when people are non-verbal, can't speak the language. What happens when you've got older people with dementia? What happens around sort of the consent process? So we really started to expose the challenges, but more importantly, and the focus of hashtag Navigating Health is the solutions. And so what is happening in plain sight is all the solutions that are being developed. So we've now had 50 people come together over the last couple of years to speak. And what we've done also, and it's not forwarding, sorry, is we got picked up by ABC Radio National, which was a surprise. This wasn't at all solicited, but they came back and they said, this is the radical act of making healthcare work for you, the patient, because after all, isn't that what a health system is for the patients? So I want to leave you with the fact that a year ago, we took our efforts global. And the reason I took our efforts global is because, as you all know, a lot of the work in navigation per se, not mentioning the community health worker work that's been going for decades, was started by Freeman in cancer in New York in the 1970s, published in the 1980s. And so what we did is went to the American Cancer Society and a number of other groups. So the American Cancer Society the American Cancer Society are working in high-income countries, but also low-middle-income countries. And it was really to start to build that work together with the work of NHS England, etc. So my last slide, just to finish on, is really just starting to say that how do we coalesce as a global group to figure out how to make this work? Because what we don't want to have happen is it to take 30 years to shift our health systems. And that is what has been happening. So this slide talks about sort of operationalizing culture change, quite frankly. Why we revolt, you may know Victor Montori from the Mayo Clinic, Richmond Group of Charities. It's just one thing after another. The WHO have been mentioned today a few times in terms of their work in navigation, but also they've done work across 150 countries in meaningful engagement. So this was a bit of a snapshot, and I'm sorry to have gone over time, but if I just leave you with our QR code, you can look at the project yourself. It is a project, it's open to anybody. But my point is that, you know, we've worked with now over 500 people in 30 countries. This is something that matters to all of us. It's not just about a health system working with people, it's us as people who start to become part of the solution in terms of what this looks like for us and every day. So thank you.
Thank you. Yeah, I think you definitely have found your people here. So we can talk about that more over the lunch break. It is time for lunch. So we've got so it's going to be a short lunch break. It's going to be 25 minutes. Sorry, we've run a little bit over time, but there's food just out there. So have a snack, get a breath of fresh air. Come back this afternoon. We're going to focus more on some local examples, and then we also want to have a conversation with you.
I'll find it and I'll send it to you. I'll send you the invite.
1, 2, 3. So I do have to get this close. You
It was just a funny.
Need that because he had functioning one back leg. Yeah. It was quite okay. Yeah. I remember how we did it. Yeah, how did you beat it once? If it's Sparrow Child, like I was usually literally a block away from Sparrow Child. Feeling that I brought it up to concrete steps up until around I don't know why. There were steps like from the street leading up to the front.
I think we'll start in like 1 minute. Let the last stragglers come on in.
Are you going to apply?
Here we go.
We can do it.
Yeah, it's not just about really
Hey, welcome back, everybody. I hope you're feeling refreshed, ready for action. I know it wasn't a very long break, but I see a lot of conversations happening. So this afternoon we're moving even more local. So we're going to hear some examples from work and programs within Sydney Local Health District, and then we're going to move on to a session where we're going to have a sort of Slido focus session where we're going to be asking you some questions and getting some ideas generated from the audience, and then we'll be finishing up with a panel session focused on kind of what do we do now? So first up, we have Dr. Esther Loon. She's a research associate from the Health Equity Research Development Unit, so she works with me. And Esther's going to be presenting on investing in community-based peer educators, engaging, enabling, and influencing.
This works. Can people hear me? Yes. Okay, great. I don't have a lot of time, so I better start. I want to acknowledge first that the project was done mostly on Gadigal land, and that this is unceded land, and pay my respect to elders past, present, Aboriginal, Torres Strait Islander colleagues, and country in general. This is also something really important to say that this was and this is a group project. So it's what I'm presenting is really the product of like a whole team of people, and people are in the room as well. So Kathy in the evaluation team and implementation team, Jude and Shane, as part of the integrated care population health kind of part of the district. So as Fiona said, I'm taking a very local angle to what I'm talking about now, but more specifically, what I want to talk about is evaluation and research, because we've seen that, the first half of today, that there's great policy support, lots of pilot projects around peer-based community navigators type role, but often the evidence for the value, the effectiveness of those roles can be a bit uneven, a bit patchy, a bit methodologically kind of weak in terms of like demonstrating the role and the value of those kinds of projects. And why that is, I think, is because it's actually really hard to do good research on those kinds of projects. It takes time and resources. And also because I guess the standard kind of evaluation frameworks are not very well suited to these kinds of projects, because they tend to focus on like predetermined metrics, protocols, behavioral outcomes, not really the process and the kind of complex adaptation and interaction that happens between the peer, the community, the health services. So one of the key points, if there's one thing that I want you to remember from this presentation, is that we need better research methods and design that are suited to the evaluation of complex kind of interventions, so that we can produce the strong evidence base that says, this is valuable, this is how you do it well, and this is why it should be supported. So in terms of the particular project that I've looked at and that I continue to look at with the team is a peer wellbeing educator project that's located in Waterloo, which is a suburb in Sydney. If we start, I think, with understanding, okay, what is the problem? Well, the problem is not social housing residents, just to be really, really clear. The problem is socioeconomic disadvantage, and also health inequities. So the fact that, social housing residents face really high health inequities compared to the wider community because of poverty, because of stigma, because of social isolation, and other kinds of disadvantage and barriers to accessing resources, including health services. And so also because the health system, as we know, that we've heard earlier, is becoming more and more difficult and complex to navigate for everybody. So one way to respond to this kind of problem is through peer-led approaches. And the particular project that I'm looking at is a health and wellbeing peer educator project. You kind of have the tagline up there. So the idea that you are not alone and you have the right support. So the project came about it was really, truly co-designed. I know this word has a lot of currency and sometimes it doesn't really mean anything, but in this case it does, because it was put together by a team that involved housing residents, people from our team, Shane, who's here, the Healthy Living Coordinator, who's very embedded in Waterloo. And so people were thinking about, okay, well, we have these problems, but what are the potential ways that we can tackle that? What are the opportunities and the resources? Some of these resources are the fact that residents themselves were very motivated to do something about their health and to support each other. And so what I want to emphasize about this particular project is that it is a health promotion project, but it's also a community building, a community development project. At least that's how the residents understand it. So it's not just a problem of like there's an information deficit, we need to educate people. That's not what the problem is. It's more like how can we enable people to be better informed, gather information, and also feed that back to the health system. So some of the aims that were developed earlier on are up there, quite big, I guess, in terms of what they were trying to achieve: empowerment, social isolation, improving knowledge, those kinds of things. And I guess I came on a bit later in the project and we started thinking about, okay, well, if those are the broad goals, how and why do we think that the program is going to achieve this? Which leads to the evaluation and the research. So as I said at the start, I guess, and you've heard all morning, so peer-led approaches, they've been around for a while. They've been used particularly in youth settings and with particular kinds of populations. But again, it's not always clear why, under what circumstances, for what reasons do they work, and how does it work? What is this black box that says, oh, this works, this produces X, Y, Z outcome? And so there's also a lot of literature that kind of shows that a lot of the emergent outcomes or things that happen along the way are not really captured, again, by traditional evaluation framework. So we thought, it was worth investing in doing the research to show how and why this works. And we did it alongside the project as it was happening. I'm not going to give you a full overview of what a realist evaluation is, but just very, very broadly, it's about, evaluations in general. We want to understand what is causing change, how, why, and also that means understanding what role the context plays into producing those particular changes. And I think it's really important that we did this collaboratively, so with the people who are implementing the project, because if together we can understand how and why impacts emerge, then we have a chance to explain the causality, like the actual mechanisms, and we can inform what we do better, rather than making wild guesses that I'm going to unpack in a minute. In terms of what we decided to focus on, and that's something that I really want to emphasize as well, oftentimes, realist evaluations in this case is helpful because we wanted to understand the impacts on those three categories of stakeholders. Again, oftentimes it's just about local residents or the community participants and what happens to them. But actually, it's equally important to understand what are the changes that we're observing in the health system and in the peer themselves. So the full breadth and depth of impacts. And not to labor this too much, but this is a kind of like visual of like understanding, okay, you have the activities, but then how and why does that lead to the particular outcomes? Okay. The aims of the evaluation then were quite broad, I suppose. And the idea was, to assess the impact, which I understand as being broader than outcomes, strictly speaking. Not debating necessarily what is the key difference between that, but just a bit broader. But so the impact on those three stakeholders, primarily focusing actually on the peer educators and the health services and other kinds of stakeholders. Explore how and why, what happens, particularly in relation to health literacy, social engagement, empowerment, those kinds of goals that were defined at the start by the team. And as I said, to kind of gather evidence so that we can inform whether and how the project can be extended, applied elsewhere. So how did we do that? We collected data through different methods. So it's mostly a qualitative study that was done primarily through interviews with some of the peer educators, with most of the peer educators, with service providers, also a lot of observations, because that's kind of like also my background, kind of anthropology, ethnographic observations to understand the kind of like social dynamic that happens that also needs to be captured. So observations of the training of the peer educators, observation when they delivered workshop themselves, and also looking at a range of documents. Okay. What did we find? Well, Kathy and I are still kind of analyzing and making sense of some of the findings. So this is quite provisional, and this is just kind of giving you an overview of what we're finding. But with the peer educators, definitely in terms of what they reported in our interviews and in our interaction, a lot of things around, kind of key health literacy, or I prefer to talk about capabilities actually rather than literacy, because it's this idea that you can build on capabilities and they're already there. So knowledge and personal skills development. A lot of people also talked about increased in well-being, and a lot of things also around motivation, confidence, feeling like they have more agency in doing things. And that's really important because that feeds into this idea of like, well, there are things that I can do about my health, or there are things that I can do about my environment. Forming networks of support, because, like to do things about your health, you also need to feel like you got emotional, informational, instrumental support. Like we all need more support, I think. And some of them also kind of like forming more critical kind of, you could say critical consciousness, social action for health to try and advocate on particular aspects of health. Also in terms of, if we look at like health systems findings, so I think one of the things that is starting to emerge is that the program in how it works is also starting slowly to change how services understand residents, how they perceive them. And that means that, the way that services operate can slowly but surely maybe be reshaped in some ways. So thinking about the fact that, people in social housing in Waterloo have a lot of, are quite resourceful. They have skills, they have knowledge. That there are different ways that you can work with people that are more collaborative and more flexible, that all of that takes time and resources and those kinds of things. But also that there's great enthusiasm and momentum around this program, which I think also speaks of like that it has a lot of trust and credibility amongst other parts of the health services, and that's really exciting. More specifically, though, what I find particularly fascinating is this how and why. So sorry about all the text. You don't have to read it all, but basically right at the start of the evaluation, we we kind of developed with the implementation team assumptions like, okay, how and why do you think this program is going to work? And so we developed kind of, statements like this, around education. So if peer educators are trusted, then it will produce X, Y, Z. How do we think, social isolation is going to impact health? How do we think people are going to be empowered? And I really see the value of research like this to think about, okay, well, we opened this black box of like, hang on, how and why do we think we're going to have these resources that are going to lead to this particular outcome? Can we understand the building blocks of that? I don't have time to take you through all of it, but I suppose with those kinds of roles, peerness is a big part of it. So it's this idea that people are more likely to engage and to listen to people who have a similar social background, right? But is that really enough? Is that all that it's about? Because sometimes in the literature, that's how it comes across. And so we really refined what that means for the peer educators in particular. In terms of thinking about what are the different pieces of the puzzle that come together to produce these kinds of more trusted relationships between peer educators, health services, and the broader community. Thanks for the timekeeping. And there are lots of pieces that come together. So it's not just about, I come from the same social background as you, therefore you're going to listen to me. There's a lot of things around motivations, aspirations, the kind of social networks people already have that they can tap into. Lived experience is important, so it's necessary but not sufficient is what I want to emphasize, because peer skills is also a real thing that people learn and develop and practice in the group, and that was really important. Another key aspect obviously is around, the way that these programs are often portrayed, as I mentioned at the start. Oh, it's about information, it's about education. Well, actually, yes and no. It's about a lot more than that. It's about what kind of information are we talking about? So here I've just put like a few quotes from the peer educators that we interviewed. So, education or information, but really something that's based on like the local context, that's grounded, that offers broad, open-ended conversations about what is the problem, what are the range of solutions that we can tackle. It's how it's delivered. There's a lot of, we had a lot of conversations around stigma and judgment and removing that and having more open conversations. And then it's also information and education, as I said, to take action, in order to take action, and how do you support that? So still working through a lot of this, but something that I want to leave you with, I suppose, is that there were a couple of things that were not in the initial assumptions that we developed with the team that have to do with the fact that, how do I put that quickly? I suppose again, as I said at the start, we often talk about community engagement and co-design, but those things can be a bit like empty signifier. Like, what does that actually mean? I think it's what the evaluation really shows is that it's really also important that, first of all, the community participants are on board from the start, but also that we look inward, and that it's also the organizational context that's really important in supporting this process. So that's why I talked about, kind of walking the talk of equity within the organization. So is really important, and I have examples of how that works, but I'm not going to have time to talk about it. And the fact also that something that we missed at the start was this idea that it had to be a collective process and something that you had to sustain over time. So this participant saying, it's not about a top-down thing and everyone gets involved and we all talk about it together. So to conclude, I think it's really particularly important in terms of one of the unexpected findings, and something that doesn't often appear in these kinds of projects, is to think about, at the level of the organization and the policy, what is it that we can do to influence it so that peer educators or community navigators can feed information back and influence and shape practices within health systems. That's it, I think.
Thank you so much, Esther. That was great. I really liked kind of the highlighting, the types of research that we need and what different types of research can really show us. And I think it linked well to some of what we were hearing this morning about thinking about those kind of, there's those sort of internal attributes and some things that people have to have in order to maybe fit into that kind of peer identity, but then there's other things that you can kind of learn and build on and unpacking that in more detail. So now we're going to move on to another district presentation, and it's going to be online, which is appropriate because it's from a central service. So next up, we've got Ms. Freya Raffin, the Patient Experience and Service Development Manager at RPA Virtual Hospital at Sydney LHD, and she's going to be presenting on a new digital patient navigator role that they've got within the hospital. So Freya, you're online. Oh, and we just need you to share your slides. Yep.
Hi, Fiona. Thank you. I'll just get up my slides. So hoping everybody can see those now. Thank you so much for inviting me to speak today, and sorry I couldn't be there in person. But as Fiona noted, it is kind of appropriate that I'm presenting virtually, so thank you for that, Fiona. So I'm here to talk about the Digital Patient Navigator in RPA Virtual, which is our first hospital in Australia, virtual hospital. So to formally kick off my presentation, I'd just like to acknowledge the traditional owners of the land of which I live and I'm on today, the Camaragal people, and also the Gadigal people of the Eora Nation where I work, and pay my respects to elders past, present, and any Aboriginal people with us today. So I'm just going to briefly touch on what RPA Virtual Hospital is for those who aren't familiar, and then I will really get into the role of the Digital Patient Navigator and the strengths, challenges, and opportunities and key learnings that come with that role. So RPA Virtual Hospital was established in early 2020, just prior to the pandemic, which feels like a really long time ago now. And we were introduced to as an alternative model to the bricks and mortar hospitals that are currently operating in our district. We've been operating for over 3 years now. We're now in our 4th year of operation, and we've undergone 2 successful evaluations. And so we've got 4 key objectives. They are to support patient flow in the district's acute hospitals by delivering hospital level care in the community. We also aim to reduce unnecessary emergency department presentations, hospital admissions, and patient length of stay. And we also aim to enhance the patient experience of healthcare. As many people will be familiar, we live in a virtual world. Most of what we access is now on our phones online, and our patients are expecting that in a healthcare setting in many ways as well. And our 4th objective is to inform the broader adoption of virtual care across the district and also within New South Wales Health. As I mentioned, we are the first virtual hospital in Australia, and this year we were accredited under the National Safety and Quality Health Care Service Standards. We are a multidisciplinary, oh my gosh, I can't speak today. We have doctors, nurses, and allied health, and we're divided into 3 arms. Sydney District Nursing, which is a long-standing community nursing service. They've been operating in the community for over 120 years. We also have a new virtual care centre and integrated chronic care team. Sorry, I just lost my slides there. Can you still see my slides? Great. Great, thank you. Don't know what happened there. So this is just a visual depiction of where we fit within the Sydney Local Health District. So you can see that we're actually a standalone hospital alongside our other 4 major hospitals, and you can see our 3 teams there. So now I'm just going to talk a bit about the Digital Patient Navigator role. So from when we launched as a virtual hospital, it became very clear that support and education would be required for patients using virtual care. Prior to and kind of in the early stages of the pandemic, as I'm sure you're all familiar with, virtual care wasn't as commonplace, and people really were unfamiliar with some telehealth and kind of digital applications. And we found that particularly in certain groups, such as older patients, and obviously patients who didn't have access to certain technologies and weren't really familiar with using smartphones and things like that. So in the very early stages of RPA Virtual, I actually performed the functions of a digital patient navigator, and that involved, in the early phases, actually going to patient homes and showing them how to use some of the technology that we were using for different cohorts. And then obviously, as that progressed, it was providing more online education and phone support for patients. But that demand really grew, and we realised that we need a specified role. So in June 2021, we introduced the Digital Patient Navigator role with the purpose of ensuring that the patient experience of virtual care is clear, streamlined, and makes sense to them and those involved in their care. So we also undertook a review of access and delivery of virtual care in August 2022, and that really validated the need for this type of role. So we currently have one digital patient navigator, Kevin, who will be on the panel later, and he works Monday to Friday business hours. And then the functions of the digital patient navigator are provided to patients by our virtual care centre nursing team after hours. So the key activities of a digital patient navigator role, just so you can see, I guess, what it looks like on a day-to-day basis, include patient education and training. So this includes supporting patients to access video conferencing for care, demonstrating how to use patient-facing applications, connecting wearable devices. So, for example, our patients might be using a pulse oximeter at home that they need to connect to an app. And if they need support to do so, our digital patient navigator, Kevin, is there to help them. Another thing that our digital patient navigator does is support digital literacy and digital wayfinding. So this includes things like technology usability testing and ensuring that the support materials make sense and are easy to understand. And digital wayfinding also includes things like how easy is it to contact RPA Virtual, how easy is it to find the contact information. We recently did an activity with our consumer network on this, and we identified some areas for improvement that we're going to build into our new website, which is great. And then on that, one of the major things our digital patient navigator also does is work really closely with our consumer network on the development and review of patient-facing materials. And the benefit and outcome of that is demonstrated by our experience data, where over 93% of people or patients find the information easy to understand, easy to use. So another thing that's really important as part of this role is the provision of digital devices to those in need. So RPA Virtual has a commitment to support patients to access the technology they need for virtual care. It's really important to us that people aren't disadvantaged by the nature of virtual care. So we do provide smartphones through a social enterprise group called Workbenches. We have a partnership with them. And we also will loan iPads and other devices as needed. And then our digital patient navigator also supports the distribution, collection and analysis of PRMs, patient reported measures. And we've collected over 6,000 experience surveys across our services, which support us in making service improvements. So the strengths of the digital patient navigator role, I've listed 5 here. 1, to empower patients and carers to engage in virtual care. So one thing that's really important as part of this role is ensuring that patients feel that they can use virtual care while they're with us, but also they can continue to use it in future as needed. So we really want to ensure that they have long-standing knowledge and skills that will support them ongoing. The digital patient navigator also ensures a streamlined experience of care by supporting patients, but also B, supporting clinicians and contributing to the development of models of care. And this really means that they can focus on the clinical care while those education components can be provided by the digital patient navigator. Having a digital patient navigator also ensures that resources are easy to understand and useful to patients around virtual care. It supports the reduction of the digital divide by providing devices to those in need, as I mentioned just before, and ensures large-scale capture of patient experience measures through PRMs. So here I've listed some of the challenges that we've experienced. I've also just noted there some of the solutions that we've identified or opportunities where we haven't implemented things yet, just for people to consider. So one of the major challenges, obviously, with virtual care is access to it. So many of our patients don't have access to smartphones. Some don't have access to the internet. As I mentioned, social equity focused partnerships, loading devices, really supports this. We do have a team that delivers wearable devices and collects them, so that really facilitates that for us. Also, one of the big challenges is digital literacy of patients and carers. As I mentioned previously, this was something we really strongly experienced probably at the start of RPA Virtual, and it definitely is still something that we need to consider now, but we're finding that over the last 3 or 4 years, people have become a lot more familiar with using technology for healthcare. But one of the things that the Digital Patient Navigator does, as I mentioned, is work really closely with our consumers, with our patients and their family members. And also, Kevin, our Digital Patient Navigator, will show carers, people's parents, children, how to use the technology so that they're able to do that with their loved one. Another challenge is supporting our culturally and linguistically diverse patients. So some of the ways we're doing that currently is we ensure that all of our resources are translated at least into the top 10 languages in our district. We work closely with interpreters to provide digital patient education and training. We also provide opportunities for patients to complete our experience measures in language using cultural support workers. They work really closely with us on that. And that obviously informs things that we do to improve our service and the way we function the Digital Patient Navigator role. And we've also recently established a multicultural access committee to further enhance this work. And then another challenge for us at the moment is evaluation of the impact of the Digital Patient Navigator role. We're in the early process of an e-health literacy study that will include a focus of the Digital Patient Navigator role, but that's only just received ethics approval, I think today. So it's in its very early stages. And just to finish off, just some of the key learnings to take away. Hopefully I've made it clear that a Digital Patient Navigator role is critical for virtual hospitals to support patients and carers as well as staff. A strong partnership between the Digital Patient Navigator and consumers is key to ensuring digital literacy and wayfinding issues are effectively addressed and ensuring that the support materials are actually useful to our patients and their families. The equity issues of virtual care are considered and addressed, and that the Digital Patient Navigator must be involved in the development of models of care to ensure that patient-centred element is addressed. So that's it from me. I don't know if there's any questions. Thank you.
Thanks so much, Freya. I know you've got to rush off after this. Yeah, I really thought it was great seeing an example of a different kind of context or place or space, thinking about how this work, we've got virtual places and spaces that we're working in as well. And, you also at the end had that key point again about needing to engage the people who are actually involved in receiving the services and kind of designing and forming that. Right, thank you. So next up, we've got another fantastic example of collaboration with a joint presentation highlighting a few different health navigation programs in the population health team at Sydney Local Health District. So we've got Ms. Brooke Daly, the manager of HIV and related programs and the priority population programs and population health in the district. We've got Ms. Athena Mumbala, a senior Aboriginal health worker in the priority populations program team, and they'll be presenting on Aboriginal health workers' roles in priority population program. And then we've also got Ms. Sue Kim, the acting manager of the diversity programs and strategy hub in population health, and Sue will be presenting on the breast cancer concierge program in the health district. And we might have time also for a few questions after that. So, thank you.
To start with, I'm Brooke Daly and I have the privilege of managing the HIV and related programs and POSHET that sits within the Priority Populations Program at Population Health.
So Athena Mumbler, Senior Aboriginal Health Worker for the HIV and related programs as well down at Population Health.
Acting Program Manager from Diversity Health.
Before we commence, I would also like to acknowledge that we're meeting on Gadigal land, the Great Eora Nation, and pay my respects to elders, past, present and emerging, and our Aboriginal colleagues who join us today. I appreciate Luanne stole my thunder this morning with a much more comprehensive overview of our local demographics. So from mine and Athena's perspective today, we'll be speaking more to the areas of higher concentration of Aboriginal or First Nation people in the district, recognising that areas of the Waterloo, Redfern, Marrickville and Glebe LGAs have much larger proportion of Aboriginal folk residing. 40% of our residents are born overseas and 46% speak a language other than English at home, which obviously, as we're all well aware, has implications for how we engage or how we provide healthcare services to these cohorts. So my role today is really just to provide a little bit of history and a bit of context to Athena's role, but she will certainly highlight the benefits of that role. I'm purely just, as I said, providing that context. So previously the role within Population Health was an Aboriginal Health Education Officer role, and it had its limitations. We recognise the need to appoint two positions, recognising men's business and women's business, cultural protocol. That's particularly heightened in our sector. We're discussing a lot of HIV, sexual health, bloodborne viruses, areas that bring up additional sensitivities, and for our Aboriginal communities, occasionally that results in a level of shame and stigma. So recognising that, we felt it was essential to have both male and female identified roles. Second to that, advocated for the roles to be place-based. So although as much as I love having Athena in the office with me day to day, really support and encourage her to be place-based, and that can be anywhere from the local youth resource centre down to Waterloo. The list is endless. And we recognise that in order for those roles to really be fit for purpose, we needed to look at what capacity building opportunities exist for those positions. So upgrading from an Aboriginal Health Education Officer role to a Senior Aboriginal Health Worker role, it included elements of, it included a clinical element, so being able to offer some opportunistic screening whilst on outreach or being place-based, and that obviously then allowed a level of continuum of care. It also included the opportunity to mentor peer educators, and that has resulted in a lot of other opportunities across the district. Yes, upon appointing Athena and Corey, our Senior Aboriginal Health Worker in the male position, they both identified very clearly and very quickly to me that the role was still not fit for purpose, and in fact we needed to consider how continuum of care looked for Aboriginal people who were met on outreach. So an essential difference, I think, with this role was around engaging new patients, not just supporting those Aboriginal patients or clients who were already engaged with the district. It was looking at how do we engage new Aboriginal clients. And it was absolutely very clear from the outset that we needed to integrate a social determinants lens to not just the role, but also our models of care to complement the roles. So where to from here? Need to continue to demonstrate agility. We need to continue to refine the duties, the roles and responsibilities, and to allow flexibility and autonomy
for our Aboriginal workforce to determine and to feedback what the community's expressed needs are as they evolve. Yeah, and I'm very fortunate that there is that trust and rapport there with both Corey and Athena, where that is quite frequently, and I would say quite efficiently, fed back, and that it's very well supported. There's a lot of executive sponsorship within population health to support these roles being fit for purpose, and that has absolutely been essential to the success of the positions. The patient navigation, so once again, just bringing it back to that continuum of care. So once somebody's met on an outreach, how does that look from that point? I'm really pleased to report that approximately a third of our clients engaged in outreach identifies First Nations. So when you consider it's approximately 1% of the local population, we're certainly, the reach is certainly there. And I'm really pleased to report that other LHDs have actually been in touch, particularly in the HIV and related programs space, to look at what they could be doing to refine their position descriptions to better align with what we've demonstrated as being effective here at Sydney LHD. I'll pass over to Athena to just outline how this looks in practice.
So part of my previous role in Aboriginal chronic care, and which has been discussed this morning, is about the actual doing home visits for one, going out in the community and just providing that one cultural support, but also that guidance for people going into different clinics, specialists, and just different health environments. So that's what Corey and I had brought forward to Brooke to kind of enhance what we all have already learned. So with this example here for patient J, she's a 52-year-old Aboriginal woman living in social housing. She's a domestic violence survivor and experiencing food insecurity. Just with the DV stuff, she was also very limited in what she would actually disclose while on site at the social housing, because her abuser was actually living in the same place as well. So it was kind of a very touchy moment there every now and then. So no previous breast screen or bowel screen testing, infrequent touch points at Redfern AMS, so the Aboriginal Medical Service, and no engagement with SLHD services. So during one of the women's health clinics at this social housing, she went with myself and one of the nurses from Leichhardt, a women's health centre, who we have a little collaboration with, like a better word, where she was, she had a 15, 20-minute consultation with the nurse and was able to, she was given her bowel screen, we made her a breast screen appointment and completed the DBS, a dry blood spot for HIV and Hep C. And out of that consultation, she actually completed the bowel screen and the cervical screen as well. And I actually accompanied her up to Breast Screen, New South Wales. This is where she divulged more information about her DV situation as well. So, once she was just with myself, she was able to just relay that back in a more kind of genuine one-on-one way. And during our little talk, a few things were going off in my head, and I thought, I know the best team where she can be referred to, which was the Aboriginal Chronic Care, which I obviously was previously with, where they had reconnected her with the doctors at AMS and followed up any other appointments that she had or was requiring. And so now she's on track with her own health, and that's what she had relayed to me in a just meeting on the street, that she felt more in control of her own health, and she just needed that little help to get through those little issues about getting there or just trying to find out the right pathway to go to. Yep.
I'll speak to another example. So Corey, our senior Aboriginal health worker, is committed to a weekly yarning circle down at, and I'm sorry, I'm Midjabari? Mudjaburi. Marrickville, previously known as Marrickville Youth Resource Centre. And on one occasion he was down there being place-based, building rapport with the young people, and he engaged with a young female, 15-year-old Aboriginal, And she was experiencing symptoms of a first genital herpes outbreak. Sorry, a first episode of herpes. She had actually presented to RPA ED a week prior and remained symptomatic. As you can imagine, the symptoms must have been incredibly acute to present to emergency. Fortunately, she met with Corey and felt comfortable enough to disclose this, along with some support from the other colleagues on site at Marrickville Youth Resource Centre. Corey was then able to facilitate referral to RPA Sexual Health Clinic and offered for Athena, recognising once again men's business, women's business, to accompany her to that appointment. She presented to RPA Sexual Health, had a comprehensive sexual health test, as well as some psychosocial care, which is really important, and had completed contraception also. So looking at a more sort of holistic, integrated model of care that could be offered for her. Obviously, purely opportunistic, if that interaction, I believe, with Corey did not occur by chance on that occasion, the trajectory for her would have been much worse. So just really highlighting and reiterating the importance of that play space and just how opportunistic engagements can result in some really great outcomes, particularly for our Aboriginal community members.
I'm delighted to share with you about our breast cancer concierge program. I think we heard a few different names of patient navigator roles, but so far I don't think we heard the concierge name. So our journey began with the recognition with not all patients are on a equal footing when it comes to healthcare, particularly patients from culturally and linguistically diverse backgrounds. Often arriving in a new country with limited English proficiency and without extended family support. They face unique challenges in navigating unfamiliar and relatively complicated healthcare system in Australia. So in response to these unmet needs, our Diversity Hub initiated this breast cancer concierge program in 2021 in collaboration with SLHD Cancer Services. This program was funded by Cancer Institute New South Wales initially. The program's primary goal is simple, but yet profound, to provide tailored support to current breast cancer patients, ensuring that everyone, regardless of their cultural or linguistic background, has equal access to quality care. So in terms of this the program model, it is actually modeled on the long-standing HIV client support program, which has been running over 30 years by the Multicultural HIV and Hepatitis Service, which sits under our Population Health Diversity Hub. Yeah, the heart of the breast cancer concierge program lies in its patient-centered approach. So we actively listen to our patients, recognizing their unique needs and preferences. This individualized approach empowers CALD women to engage with their clinical care teams and actively participate in their care decision makings. So we provide also culturally sensitive support. Cultural sensitivity is not just a buzzword for us. It's a fundamental component of our program. So, we developed a training package in collaboration with Cancer Services, and we trained our cultural support workers who are casual health employee, employed by our Diversity Hub. We have a pool of cultural support workers, 180, in the morning when Luann mentioned, about 180 cultural support workers across 30 priority languages. So these trained cultural support workers serve as concierges and provide support in the patient's preferred language, respecting their views and also understanding their cultural practices. So we understand, health practices and beliefs can vary widely among different communities, especially when it comes to something as sensitive as cancer. So this program bridges these cultural gaps by providing support that respects and acknowledges these differences. Our program provides telephone-based support weekly or fortnightly for up to 6 months, depending on the patient's needs. So this actually approach effectively reduces barriers to care, providing a sense of security for patients, which means having access to someone who speaks their language actually allows them to reach out when they have concerns or more information during their treatment or recovery process. Oops. This program initially implemented as a pilot program from March 2021 to May 2022, over 14 months. We trained 15 bilingual cultural support workers for the concierge role, and 21 out of the 23 referred patients from Concord Hospital participated in this program, so indicating 91% enrollment rates. Which means this program is quite acceptable among our CALD patients. These women enrolled in the program, they represent diverse cultural backgrounds such as Arabic, Chinese, Italian, Korean, and Vietnamese speakings. They received a total of 177 support phone calls from our trained concierges during this pilot period. The implementation of the pilot BCCP was a collaborative effort involving a diverse working group comprising medical, allied health, health promotion, and support staff, all of whom worked really hard to implement this program successfully. So I think, as I mentioned about the evaluation, so to evaluate this pilot program, we conducted a qualitative study involving in-depth semi-structured interviews with patients enrolled in the program, as well as bilingual concierges and health staff, including cancer clinicians and allied health professionals. So this program, the qualitative study was approved by the ethics committee in the district. The findings actually shows findings were really both enlightening and heartening, demonstrating the positive impact of this program on the experience of CALD breast cancer patients. Actually, it demonstrated bilingual concierges played a pivotal role in enhancing CALD patients' health literacy by providing tailored information and explanations based on the patient's individual health literacy level. So this made actually the more complicated medical concepts, or system more understandable and empowering CALD women to voice their needs to their clinical care teams and navigate the health system better, and also access to appropriate, cancer support services available in the community. So, building upon the pilot program's success, we are, reviewing how we can integrate this program into the core program within the Diversity Hub and cancer services. So, and then this model also has the potential to be expanded into different population or different language groups, and can be also adapted into different cancer streams, not just breast cancer, and also different care settings. And also the success of this pilot program highlights the importance of collaboration and collective learning in nurturing culturally sensitive or responsive care between clinical services and multicultural service units like us, Diversity Hub. So I believe this implies a direction for future similar initiatives, like providing the more equitable or culturally sensitive care requires more than just language support. It requires, collaboration and collective learning involving all stakeholders, including our child patients, families, and communities, to gain deeper understanding of their needs and also provide care in ways aligned with their, the preferences. I'd like to leave you with a couple of quotes from our qualitative study. One patient mentioned that, what I had wished was that having someone who could show an interest in me, listen to my worries and frustrations, and provide actual help. This program provided those things. I hope this program can remain until I get well. And another quote from a breast cancer clinical nurse consultant captures the essence of this program beautifully, saying that I think the model is excellent. All the women I've had referred to, I thought that they gained a lot from it. I think it's good to be able to give them that extra support in their own language. That's the beauty of the program. They are not opening up to me. They are opening up to someone who speaks their own language. So, I can't complain. So I think it's a really beautiful comment. Thank you, everyone, for listening.
What are you thinking? I was wondering, within population health, it seems like you've got a number of different models that kind of somehow fit within this loose category of care workers. And I'm wondering, do you sort of think of them in a collective way, or is it more like, you've just got these?
Yes, that's correct. I would suggest it's similar in theory, but when it comes to implementing, it's certainly recognising the cultural nuances that exist within the beneficiaries of that work. In regards to the first example that comes to mind for me, and a conversation I was just having with Shane Brown about Aboriginal young people being peer educators, and he asked me what did I envision, and the response was pretty much the cultural support program transferred to Aboriginal young people. So I think the foundations are similar throughout, but obviously recognising and respecting the cultural nuances that exist within that. Is that, yeah?
Yeah, well, thank you very much for that. That was great. I thought it was, for me, some of the stuff that came through the place and being there, and then hearing a few examples of kind of there's a whole lot of different things happened along the way, getting a sense of that, and then also that other example of just the importance of being in the places where things need to happen. And then also the technology another one to add into it. And the other point also that really came through, collective learning, that need for collective learning. So it resonates a bit with what Esther was saying as well, I think, about that. It isn't just, the people receiving the navigation, learning something. It's about the system learning and also. Thank you very much. So now we're moving on to kind of the section of the program where we're wanting to hear from you. So we're having a small session before we move on to the final panel session, where we're going to be using Slido. Yep, there it is. Yeah, so if you head to the Slido website, so slido.com, and you enter the Slido code, which is 1513122, it's in your programs and it's up there on the screen on the top left as well. But we've also got roving mics as well for the next session. So I'm going to hand over to Associate Professor Margot Barr, the Acting Director of the Centre for Primary Healthcare and Equity at UNSW, and Mr. Ratu Marika, who's a Masters of Global Health and Health Leadership student and an intern with us at the moment. Great. Over to you guys.
Okay, now, so this session is about people having your turn to answer some questions. So we're going to get started by the first question, which should come up on the screen, which is just how you're feeling today. How are you feeling at the moment? We've had quite a few people talk about being in a room with people that think like them, but just using an emoji, answer how you're feeling at the moment. And this is just to give you practice at using Slido as well. So people's answers should start coming in. I can see it on the back screen as well. So you don't have to think about the answer too much. It's more about having a practice, and then we'll move on to some of the other questions. Or you can answer with a word if you don't want to. I have to admit, I've got better at emojis. I used to send my gardening group all the wrong fruit. But now I've realised that certain fruit means certain things. So yeah, be careful with your emojis, but words are emojis. But you know, we'll take them on face value. So I'm feeling inspired by it all. I think we've had a great session. And also, I suppose the other thing I'm feeling is from some of the first, Shane's here, some of the first work we did with Shane, evaluating the Navigator program that he was working on, and how much more, you know, how far we've moved ahead. And of course, you know, we gained a great understanding about, you know, the complexity of the navigation, you know, those navigating roles. Okay, so there. All right, well, how about we go non-tech and people just yell out to me what they're, just tell, people call out some words that they're thinking about. Good. Good, what other words do we get? Sorry? Inspired. Happy? Inspired? What do we get from this side? Liz, what do you feel? Relieved. Relieved. Been very good. We got some more people from the back of the room. Ben, you're sitting there quietly. What do you?
Excited.
Excited. Yeah, that's a good word. I've got a few thumbs up. Somebody's clapping. And I've also some more goods. I have 2 flamingo dancers. So who did? Yeah, who is that? You need to get up and dance. Whoever those people were that put the flamingo dancers in. Is that are you one of the dancers? All right. So, okay. I think, so let's move on to the next question. And the next question that we have is, in 1 or 2 words, what was the main take-home message that you've learnt from the presentations? And I would say good luck doing it in 1 or 2 words, because there's been so much. But, you know, whatever, some of your thoughts that people have. And some of that is sharing it now, but it's also collectively for us to get an idea, you know, idea of, you know, what people are hearing about, but also, you know, you can also be thinking about your thoughts, like what next, or, you know, how can we change the system? So it doesn't have to necessarily be a take-home message. It could be a thinking about what's next. So if people have words that they want to enter, is this your phone? We'll see what happens. Otherwise, we can go old school again and people can just yell out some of their answers. But it is being captured on the system.
It's coming up on our phone.
It's coming up on your phones. Okay, wonderful. So some of the words.
If you entered an answer on the computer on the screen, it might take you to display.
Ah, okay, let's try that. Let's go. I just put complex.
There we go.
No, but I want to try. Can I try this one? Putting a word. Ah, look, it was me, not the system. Thank you, Ben. This reminds us of when Ben and I do our hybrid class. I just go, too many moving things, and Ben very calmly says, press the button. Okay, so some of the ones we've got: learning from each other, supporting navigators to be effective, human connection, working together, understanding how it works, need more time, similar challenges, respectful engagement. Okay, so that's, people have done well with one or two words. The potential to add value to patients, I think, is an underlying sort of philosophy with regard to the whole, using navigators or community health work, of how can we make it easier to help people navigate systems. All right, I think I've been cut down for 10 minutes for this bit, but let's try the next question, which I will answer this time. What is it about the health system that means that we need community health type roles? You can read the examples, but what is it about the health system that means that we need these types of roles? And I think I'll use my complex one again. It's so complex. Fragmented is popular as well. Complex? Come on, more complex, people. It's interesting, isn't it, the complexity of it? Oh, okay. We've moved on. Can we go back to the last?
Moved on.
Do you want to just send us back? Yeah, let's have a look and see. So healthcare navigation is complex. Too many doors. Change the way we do things. Value for money. Silos. Workforce shortages is, I suppose, is it a workforce shortage, or is it that we've got a lot of people doing similar or the same thing, or alternately doing a lot of paperwork documentation when they might be able to do other things. But lots of really good comments. Have we got time for one more? Maybe we've got time. What time do people want to go home? What do you think the knowledge gaps are, and what research do we need to be doing? So that's not a good question as a survey methodologist. You've got two questions in there. So choose which one you want to answer. Either you're answering what do you think the knowledge gaps are, or what research do you think we need to be doing? So, and look, some of the presentations we've talked a little bit about. Okay. So, best governance arrangements, how to fit into the existing system. Well, even those things have. Oh. We've moved past that, maybe. But do we know the answer? Does it work, and in what situation? Do we know the answer? No. scope of roles, supervision needs, the training, and I think it's interesting that whole different ways of looking at training and some of the training program and how best to do training. Policy, CHN, a community health navigator. Code. So the person that put the code, is that more research in the code area to understand better what's happening in different populations? Okay, can we do one more? All right, the next one, and it's nice, it's fun to play with your phones, but it's also nice to have a chance to do some feedback. Next one. What do you think? Who do you think should fund these community health navigator positions? Has to be the Commonwealth, surely. That was the survey I did when I was at the health department, is what percentage of the population would be happy? Teresa. A Commonwealth's winning. We could send this back to the Commonwealth. Do we have any Commonwealth representatives in the forum? So we did also talk about whether they're funded positions or voluntary positions as well. So that whole question about who's paying and do people need to be paid for these positions? Oh, Natalie, you're doing it. Well, maybe we start a GoFundMe page. Huh? Where's Brendan? Is Brendan still? He's gone. Okay, we can send that to him. So some NGOs, not voluntary, and I agree. I think it is something that it's people are doing work and should be paid for that. And then it's working out how best to. I think the other thing is, and here it doesn't matter who, just needs to be secure employment, and I think that's really important as well. We also have to navigate that in the research area as well, secure employment. So I think, how are we going with time? Don't close this yet. Okay. People are still putting comments in. And I think we've only got one more question, I think. Or maybe two. One more. This is it. Last question. What is needed to make community health navigators sustainable within health systems? Oh, that's a small question. Money. But it's more than money, isn't it? It's about changing attitudes, maybe, as well, which we've been talking about as part of the sessions earlier, particularly in the New Zealand example where it's 10, 15 years, and then as an attitude, and even, well, I would say last 5 years or more here, attitudes have changed. So we've got recognition, commitment, sustainable funding, and community involvement. That community involvement thing is really important. Helping in the community and navigating the health system, you really do have to be involved in the community and be accepted by communities. Motivation, education, proper training. Which I think is, there is that element of, consistency perhaps in training, but also in what was presented earlier, this idea of having core modules with other electives that you can then add depending on the actual role. And also what we talked about before of this, I'd never really thought about it. I like definitions. I'm an epidemiologist. So this idea of does it matter if we've got the same definition, I think that was sort of challenging here a little bit. But I understand that that's important too. It's about the roles and the responsibilities, not so much about what each of the positions are being called or the different programs. And a strategic plan. I like strategic plans. But it is that thing of where are we headed? And I think that's a nice sort of segue into the panels. So there's quite a few people who are going to join us on the panel. So thank you for everyone. A clap for everyone for your answers. It's great both getting the answers, but also having a think about what's important. The other part of it also is that we're looking around, keep the conversation going, the community of practices. We can talk, you can send in ideas and thoughts to Kathy, I suppose, is the main point. And then we can, so that people, if you've got questions of some of the speakers as well, send in those questions. Now, the people for my panel, we have Athena. You're here already. Thanks, Athena. Vanessa. Teresa. Kaya. Kaya. Okay. Rebecca. Jessup. Sarah. Yes, I saw Sarah sitting before. Sarah, you're up the front as well. Natalie, you're already there. Okay, no problem. Mark, you're on the list. And Kevin is on there as well. Is there anyone else who was told that they were going to join the panel? This might be a spare seat for me. Or I can stay here. Where do you want me to be with microphone? Maybe it's here. I'm looking at your back, so that's the only trouble. What I'd like to do with this panel session is what we'll do is, and you've met most of the people on the panel. There's a couple of people you haven't met yet, so I might just get those people to introduce themselves. So Kevin, do you want to just introduce yourself first?
Yeah, sure thing. My name's Kevin. I'm the digital patient navigator at RPA Virtual, so who Frey was speaking about. And yeah, it's lovely to meet you all, and thank you for the opportunity.
And Teresa, yep, go on.
Hi, I'm Teresa Tan. I'm a new navigator. I'm starting my role in March this year.
And you're a community health navigator?
Yeah.
Yep. And Vanessa, I think we didn't meet you before.
Hi, everyone. My name is Vanessa Lu. Thank you to invite me to attend this roundtable discussion again this year. I practiced as a community health navigator's roles 3 years ago. Started with Professor Mark Harris and I joined Elizabeth Harris.
Thank you.
I work for the Plan Care and Sydney Health local district demo.
And Kaya.
Yes, I'm Kaya Fleming. I manage the Plan Care team in Sydney Local Health District, including Teresa and Vanessa and one other community health navigator.
Thank you. And then the other people have already been introduced. So what I'd like to do first is just go around the group. And one of the things we talked about is often sustainability or scaling up, or how do we think about where we're moving to into the future. And how would you describe, what does success look like as we move forward along this sort of avenue of looking at how we can make community health navigators or community health workers more sustainable? And it can be from a training perspective, or it might be from a client's perspective, or the health. But just from your perspective, what does success look like? So if you would like to start, Kevin, I'll put you on the spot. And yours is more in the virtual.
Yeah, no. I think success, I think it centers definitely around the patients from my experience working as a digital patient navigator. So I suppose in my role where Freya oversees me and she's given me the opportunity to really look into our experience measures, particularly, and I suppose as she mentioned in her presentation, it's very important to be collaborative. Particularly, I really enjoy collaborating with our consumer network. Personally, I actually worked as an allied health practitioner prior to this role, and so collaborating with clinicians is very important too. And I think, yeah, in my role particularly, being able to take off some of that navigator role and help our patients access virtual care, and then the clinicians can really focus on clinical tasks. And the role has now moved into, as we think about future and new models of care and so forth, being a part of that implementation process and considering the needs, the digital literacy needs of our patients, particularly in our local health district, is something that we're really focusing on forward. So.
Thank you. Teresa, what's your thoughts? I know you said you're very new, so
yes,
maybe you're...
Yeah, but I have a few words. So this role is quite new for me, and I'm still learning. And I'm also myself on visit elderly and all age people out there. And I identify the health issue, and I also identify cancer like me. And for me, I think if I'm a community health navigator, I have responsibility to make sure all these patients or age people out there, they just discharged from the hospital to make sure they receive the care they need and what they need and the time, the right time of care, and by who and by the team or in the right place, and to ensure they not risk of avoiding hospitalized again. So this is like make the hell, save the time for everyone.
Thank you. Sarah.
I would like to raise a concern of mine and to look at success of community health navigators.
You'll need to speak up, I'm sorry.
Sorry, is that okay? To avoid that to happen. And my concern is that obviously there's a growing interest and great works happening around community health navigators in Australia. But there are lots of different programs, like we've got palliative care navigator, we've got recently like in South Australia, we've got voluntary assisted dying care navigator, we've got like different care navigator programs, and in the future we gonna add another layer of complexity for patients with multiple like health conditions or problems or issues in navigating the system. So finding the right care navigator would add another layer of complexity. So for the program to be successful, I think that there should be a kind of shared vision and shared standing at the more national level, I guess. Make sure that they're not working in silos. The care navigator model is not disintegrated as the other healthcare services.
Okay, thank you. Rebecca, what's your thoughts?
Lots of them. One is I'm wondering whether I should have worn stage makeup, but with the lights, no, just kidding. So I know today we were talking about, there's lots of flowers and we need to nurture every flower. But I think one of the issues we have with so many different types of roles is that there's no capacity to act as a collective. So we don't have the ability to create a collective agreement for pay scales and for opportunities for advancement. I think that's an issue. I think that when we have a training package, which we hope to deliver next year, we hope to address some of the funding issues in hospitals because we're activity-based funding and they recognise allied health assistance, and we're hoping we'll be able to get some recognition for these types of community navigator roles as well in that space. But we do need to address the funding barriers. And my long-term vision is that I hope that there isn't a cis white woman sitting up here talking about care navigators. It's actually people from the diverse communities that they come from talking about the work that they do, which is happening. But I would like it to be exclusively owned by the communities that are around me.
Oh yeah, your turn. You've got a choice to.
Yes, well, I think following on from what you both just said, I think part of my role is being really clear of what a community health navigator does, and I think I've seen that in my affairs with a multidisciplinary team with nurses and social workers. People aren't exactly clear on what they can do, and everyone comes from their own discipline thinking that's what a navigator should be doing, or focusing on different areas. So I think being clear of what the role is, and even just after today, wondering, the term navigator, I've worked with 3 different navigator roles in the health system, which are completely different, and I don't think the name navigator, I probably feel more confused now than I was at the start of the day of what a navigator actually is, and that probably adds to the confusion of staff confusion, but not being so clear on exactly what the role is, and that's what we're working on as a team, to be really clear within our own team and then be able to clear on it as well.
Next one, Vanessa, isn't it?
My 3 years as a community health navigator journal was very interesting and very rewarding. I go through the and downtown so much day. But one of the things is I love to learn the new things. This is my passion. And the other passion to drive me here, still here today, is love to help people. That need really infuse passion for it. Now, for the most questions I meet since I work for the senior local health district is asking what your role is, what do you do, what you can do for us. So the definition is definitely there. And the interest part is I usually explain very simple sentence to my clients, my colleagues, so health professionals and service provider is I'm here. I'm a community health navigator. My role is a bridge between the health professionals, specialist doctors, and and also the bridge for the clients. That's the center clients care, and another bridge is for the service provider. So you might both have no issues, but you might have some things you never communicate to each other before. So my role is here to fill in the gap. It's very simple to say, but very hard to show the people what I actually do. So that in terms of debating what my role is, how I define my position, I want action. So I do the joint home visit with our team members, and I open-minded and acceptance whatever the system are. And then from that on, this is one of my interest role is identify the barriers. This can be one of the barriers is like how we integrate into our health systems. And it's very interesting to see is through the journals I did through, with the team leaders' strong support and our team members' strong support, and we achieved the agreement today is we want to promote this role in the health systems, and we see so many positive feedback from the clients we meet every day, and from the GPs and the specialist doctors, also from a lot of the service providers. I never noticed there's a gap or gaps down there. So our role is basically like brokers filling the gap. And the interesting part of this role is because you meet the different clients, they all have a unique story in lives. And we have to open mind, not judgment to any cases, because the case applied to these clients maybe not, even you feel like it's similar or very, like have their own experience or maybe something, but never judge people, because it's always come back to discuss with the team and get the best options. Then we go back with our clients and give them the options and choices and respect their decisions. It's not our decisions. Our role is open mind, acceptance, and find the barriers and trying to solve the barriers and try our best to solve the barriers. But we also have to. Oh, sorry.
But you've been touching on. We'll come back to that in a little bit. So, Anthea,
So it's already been touched on. It's about having, well, from my point of view, Aboriginal health workers or Aboriginal outreach workers, making sure it's culturally safe and culturally appropriate for not just cultural support workers, for Aboriginal health workers as well. Because if you don't have a familiar face, you're not going to get the help you need, for one, if you're the patient, but also you're not going to have that person to help support if you're that health worker as well. And it's also about sustainable. The employment is the most important thing as well. We've got to have more Aboriginal health workers within health services, because there's obviously a big lack of it, and it's needed on many levels throughout different services as well.
Mark, your
yeah, one thing that was mentioned this morning, which I think is really important, is that community health workers, overseas at least, have been shown to be one of the most effective tools that we have in the health system to address health inequalities, health inequities. And so I think we need to keep that in mind. So that's one thing I wanted to say. The other thing is that I think while, 1,000 flowers blooms is a great idea, and I think we do have to be flexible and not get too obsessed about definitions and so on. I think it is important that the health system at least start to understand what community health navigators are. And, with flexibility and with fuzziness around the edges, what the core roles might be, and what their value might be. And it's when we've got that, I think we'll address issues like integration and sustainability and so on. I think there's been a tendency in Australia to create a plethora of different roles, whether it's around particular diseases or particular population groups, and it's absolutely understandable why that's happened. But I think it makes it very difficult to develop a sustainable workforce that can move, as Vanessa has done, across different environments. So, for example, from general practice into post-hospital care, and I think it makes a lot of sense. I don't know how you shut the door. It seems that if you shut the door, it makes a noise. If you leave it open, you've got a noise outside.
If you shut it, it should be all right to shut
Natalie.
Can I give my 2 cents worth? I feel like everyone said most of the points. I mean, to me, the real sign of success is that it would be far more widespread. So we've heard lots of fantastic examples today, and I think we've justified the need, but I think we hear about in other countries there's a lot more of them. And I would like to see that we're not having to argue why you need them in Australia, that it's established that it's a really important thing. And I think the points around consistent naming and that kind of thing would help that. But yeah.
So there is the opportunity for people to, I think, by a slide, okay? But while people are doing that, so you can go on the Slido thing and put any questions in that you want. But while people are putting their questions in, I suppose one question that I'd like to ask the panel, and I'm happy for people to raise their hand, actually rather than virtually, is this whole thing about the health system and the health system's role in supporting community health navigators or community health initiatives. So how do you think the system needs to change, or what's the role of the health system more generally to embrace the community health navigators? What are people's thoughts in that space? What change needs to happen? We've been talking a lot about change, how, to make this, to move forward and think more about having community health navigators or community health workers more embedded in health services. How does that service? Or maybe they are changing already.
Well, I think the health system is changing so quickly that the navigators are so needed. I feel like I need my own personal navigator working in skin local health district. We have so many things happening and so many new things all the time. And I think that's another challenge with our team with chronic and complex care patients, trying to know which services we can refer to. So I think working in the health system, we're still trying to work out what's in the district. It's even more challenging for people in the community. And I think probably we're not going to change the pace that we're moving at, but I think the community health navigators can link up primary health networks for GPs to know what we're doing as well, and or staff in the facility, but for the patients to know how to get through the system and the best way to referral through different systems. It might not just be that one place, but being able to refer through different health professionals, but also other health navigators.
Any other thoughts from the panel? Natalie.
I think at the co-design phase of any new program, we should always be including a part around navigation and working out what the important. So any kind of program policy design at a government level should incorporate that as part of it.
What are you saying to date is afterwards rather than perhaps thinking about it time that it's been?
I think so. I mean, there's been some programs, I know the Care Finder program, for example, has been designed purely around navigation, but I feel like a lot of like my aged care, for example, should have had that component in it because it's already very confusing for people. And any big government program really should think about that. I mean, ideally, we wouldn't have, our health system would be a bit simpler. That is the ultimate goal. But I do think that people know how complex and difficult it is, so they should build that into the design of their programs. And when we're doing programs at a local level, so say our PH, and when we're co-designing programs, we need to build that in as part of the process as well.
Can I ask you from more of an international perspective, what do you think the successes have been with how health systems have, I suppose, embraced community navigators in other situations? You've got some sort of reflection on that?
I think one of the key factors is having that broader policy and political will around community health workers program, because I think still there is a confusion that how this role is defined in relation to other health professionals. And for some, there is a concern that it's duplication of role. Like, for example, how you distinguish the role of community health worker with a social worker, for example. And because of that, there is a resistance to accept and to integrate and incorporate the role in the broader health system. So, I mean, in a country like Iran, which is, like, as I mentioned, it's part of the health system, there is a national commitment that this is how works, and it's the effectiveness of community health workers program, especially in rural areas too. And there's been lots of research and studies showing that how it improved equity, how it improved health outcomes for rural population. So I think it's not clear in Australian context that how other health professionals view the role of community health workers and how the health system views the role.
Just very quickly add to that, I think there's quite a lot of fear amongst health professionals about the role boundary crossing, and I think that there is a real lack of insight into the level of health equity gap that exists. And I'm going to actually steal one of my colleagues' stories. It's not my story, but one of my colleagues who said she used to be absolutely terrified of providing life-saving CPR as a doctor. And when she was first out working as a doctor, one of her supervisors said to her, "The person's already dead. Anything you do is going to be an improvement." And I know that sounds really melodramatic, but we have got communities that are not accessing care at all. And so what could be worse than that? There is nothing that is worse than that. So actually anything we do to improve that equity gap, even if sometimes we go a little bit into blurry role boundaries, is going to be better than what we have.
Cut you a little bit short because you were starting to talk more systems. Did you want to add any more comments about the system?
Yeah, for sure. I think team leaders in the management need to promote this role. Yeah, a lot of people don't know this role exists. So we need to promote this role, especially within the health systems. And I had a lot of vulnerable clients. Actually, they need like managed care or ACAT or REST assessment. But we found an interesting part is like, because they don't know our role already, like this client is already in our team, plan care team. So they trying to contact the clients a couple of times and no contact on their role. It's just plan to discharge them from the team. So in order to like that happen again, if the health system other teams already know we already exist as a plan care and also a community health already involved, they should be able to easy to like just contact us by email or phone, say, "We can't find this client. Can you able to help?" This is actually our role. Very simple email, but just because the health system majority other people at the team doesn't know we exist. So that is the gap stand there for sure. Now in terms of the GP, I found the feedback is 100% feedback from the GP point of view, because at the moment the charge is high, especially GP fee is going to increase again. Now a lot of patients I meet is they're vulnerable or have a financial difficulty. They choose to come to the ED instead of go to the GP because it's free of charge. Now that could be our future issues for the health system. It's a huge impact for the hospital rates. So in terms of doing that, I think we need to promote within the GP to telling us where exists. If you find some clients or potential clients, maybe like that, please refer to our community health or plan care team. So our CNCs produced a new network for the referral network for the GP, which is very convenient for them. Or they need to just refer on our systems. Yeah. The other promotion we should do is from our service providers, because we found a lot of people have HCP or CHSP codes, but the service providers, I wouldn't say the percentage, but a lot of them actually didn't provide a service properly to our clients. I have some clients like the service provider told me, the case manager said, "Oh, we provide 4 hours service to these clients twice a week, blah, blah, blah." But when a client said to me, "Oh, I only see you 2 hours per week," and the other girl never turn up, or some caseworkers may be on holiday that the case manager even doesn't know she's on holiday for 4 weeks. So which means our clients doesn't have any services for 4 weeks. Nobody noticed that. And we found out that this is the huge gaps down there. So we need to promote our role as well. Is one of our role is educator service provider, especially the case manager. Please take the responsibility to look after our clients. Yeah, because we believe it. Once they sign for the HCP, it's their responsibility. And the other major.
I might just pass on to Anna.
Sorry.
Can I ask your opinion on that as well? The whole question seems to be about people understanding the role of the navigators, and that it's not only the clients but also the service providers. And how have you sort of navigated that in the work that you've been doing?
It's interesting because I was having a conversation with Shane about what happens when you get to a service and they don't understand who you are and how do you kind of fix that little mistake. And it's about the promoting and educating services, whether within internal services or even external services, to understand about Aboriginal health workers or cultural support workers as well, just to have, so those services know who we are and what we provide with our clients. Because if you get that pushback and not knowing what's going on, the client, again, is going to be the one who suffers, not having the service and not having the support that they're needed. So it is the promotion of the whole cultural support workers, Aboriginal health workers, outreach workers, navigators, all of those. Yeah, it needs to be, massive in service to all services in every district, really.
Now, we've got a couple of questions that have come through. I don't know if people can read them out better. We might go, well, the first one, how do we maintain the connections we've made today? What should we do next? And then the second question is, there is a golden opportunity for health navigators to point out the gaps in service. Are there any responses to this? I'm not sure exactly the second question what they're I think let's go with the first.
Could I just respond to the second one, because I think I know the answer to that. I think what it's saying, and this is something that's been demonstrated with community health workers and outreach workers and boundary spanning workers and so on, is that in addition to addressing individual patients' needs, it's possible, and this is really an issue in this case for the whole of the plan care team. It's obviously possible to identify system problems, systemic gaps that really go beyond what might be appropriate for an individual. So Vanessa's example of the issues around aged care, people have got aged care plans and we've got people being funded to provide services, but not happening, for example. So that's a more systemic issue than just one person. So it's and I think one of the ways that gets addressed, and it's a pity we haven't got Fiona from this morning to talk about this, is in New Zealand. I think they've found that some of those systemic issues get picked up by the team and the service that they're part of. In Fiona's case, it's the primary care network in the South Island of New Zealand that gets to try and address some of those problems.
Does anyone else want to make a comment?
That was my question.
Yeah.
The problem is that there's some politics around that, and if you're seen to be critical, it makes your navigation role more difficult. So it's a very fine balance.
Yeah, it obviously is, and I think that's why I was saying I think this is a team responsibility, and that's why it's important that or a service organisational responsibility. It's why it's important that the navigators are part of a team, part of a service, so that those things can be escalated and taken forward, rather than the an individual navigator taking that on.
Now, I've just heard the bell go, so I think we've got a couple of minutes. The last question there is around the building credibility so that navigators find it engage health services that are needed. Does anyone feel comfortable to try and answer that question about how do we build credibility? It's back in that system area again, and what Mark was talking about before, a bit around, as you're trying to navigate the system, and also I think, was it that mentioned, Kaya, you mentioned about the change in the systems that it keeps changing. So how do you keep up to date with knowing what's happening and what services to help people navigate, but also that credibility of your role? So whether anyone feels like answering that or having a go at answering that question.
Can I answer?
Yeah, sure.
Yes.
Just pop the microphone.
So I knew my role is community health navigators, not only identify and not only like to have support services and not only link services. I also encourage elderly or people, young people at home, because they not with community navigators for long, just only short a period of time. So I prompt them and then give them education. If there are issues with, with service, they can contact the service provider straight away. So instead of live for a long distance of time.
Yeah, so that is your navigator role is to help people navigate the system, but not, you don't always have to be there helping them.
Yeah, because I knew they can't be with me, every day.
Okay, so we might end on that. I think that's a really good point, that the are there to help people understand how the system works. And so some of it is you helping them with information, but others of it is giving them the skills to navigate it.
Who to contact.
Part of our role is supporting our clients to have a self-navigation.
Yeah, great. Thank you very much. Panel.
Thank you very much, panel. So we're getting to the end of the day. Sorry we didn't get to all of the questions. We're going to send them to the presenters and see if we can collate some responses as part of our little workshop report. So now we've just got Kathy O'Callaghan, research fellow you've already met earlier on today. Kathy's been listening the whole day, kind of taking down little notes, and she's going to attempt in a very few minutes to kind of like just draw out some of the key themes that she has observed during the day.
Thank you. So we've had a very busy day hearing about international programs, national programs, state programs, and what's been happening within the district, and very broad overall themes have emerged from this. I think we don't need to talk again about the importance of community health navigator roles is well established, but today we're also looking at how can those roles be supported and sustained in the future, and what works for whom, and what needs to happen in the future. So there were two major themes all from today, and so looking at the roles, we really, there was lots of confusion, too much discussion about roles. There is a diversity of roles, but the importance is to understand the roles for people around those roles, but also for people actually in the roles to understand what boundaries they have, what in terms of health professionals and clinicians. It was really interesting to talk about the fit for purpose, so some of for the Aboriginal health workers, and even in New Zealand, what's was really being fit for purpose is really essential to success. So that co-design and working around what fits for the actual service for the roles in context was another real key theme coming through. The roles are changing, they're evolving, they're not just place-based, they're virtual, but also for these roles having that collective. So just getting funding for people to go out and spend time negotiating and working with patients, but actually having that capacity. So that's where we talked about really strength-based, what's the essential ingredients, what's the training that's needed. So there's core essential components of training, but then there's these electives too, fit for purpose. But also capacity frameworks are developing, so not just standards, but building that capacity again, and talking about the worker, about safety around that and boundaries, which can be very difficult around that too. And I know during COVID, that's one of the things that happened in the district around boundaries and, especially in new areas, fit for purpose around pandemics and, having those boundaries. And what was really interesting was looking at the social determinants of health and doing a screened social determinants screening. So having peer health navigators being generalists, not population-based, but more looking at the overall person-centred approach. So those generalist roles around with working in children's healthcare, and in the Canadian model as well, which was so long ago this morning. And then, so the next major theme is the supporting and sustaining. So what was really interesting too was linking back to the health system. So even when we're talking about the New Zealand model, was actually having navigators being able to be contacted and being reliable and delivering. So just things like that. And then, they've sustained that model for so many years. 75% of the people have stayed with the program. And also around integrating with the service, we heard about the peer educators, the importance of linking back into the health system, having the importance of action. So not just going out working with your communities, but how do you actually feed that back? And that led into the support and sustainability and success. So the health system, there's fragmentation, complexity, and lacking, there's changes in roles. So, doctors can't do everything. Clinicians, they're not working that's not their area, but there's, so many changes. So that's going to continue. And I think, as Natalie said, getting worse. The complexity of care that we all know about. So the importance of funding, commitment, recognition, and being part of the implementation process. And the great idea about thinking about for all projects, thinking about patient navigation and how that feeds back into the co-design of the program. And just some discussion about research and evidence, the limitations of randomised controlled trials, but there's all these great programs happening at the moment. The importance of more realist implementation science evaluations, but also looking at effectiveness and just a point about, it actually makes, a lot of these programs makes life easier for providers. It's not just being a bridge, but actually reducing that gap as well and feeding that back to health providers. And of course, we continue to do cost-benefit analysis and all those sorts of things to feed it back, which we're driven by. So they were the major themes of based on everyone's talk. So hopefully if there's anything I've missed or some other theme you felt, let's keep talking. Yeah. Okay.
So that brings us to the end of the day. So a big thank you again to our partnering organisations, our panel members, our audience, and also our event organisers. So a big thank you to Miriam Olek, who's Strategy Engagement Communications Manager. She's been sitting there quietly behind the scenes all day, but you've probably noticed, there's been a lot of work going on, and she's been organising that with Kathy sitting next to her. And Liz Harris has been really sort of vitally important in terms of like bringing together all the speakers today. So there's been this little group working in the background, and I'd really like to thank them. So if you have any questions, comments, or feedbacks about the forum that you'd like to pass on to us, just let us know, but we will also be sending out like a little evaluation form. So in terms of what happens next, we're going to summarise the key points. Kathy's already halfway there, and we've recorded today as well. So we'll sort of package that all together and share that with you. We also, we'll begin planning for what we're going to do next, and we've had a few of these forums now, and it seems to be that people are finding them like a useful opportunity to come together and keep progressing the work. So I think one of the things we'll be thinking about is, what are we going to do next? For those of you who are here in person, there's some refreshments still outside. Please help yourself. Feel free to hang out, have a chat. It's, so nice to have the opportunity to actually be together, and hope you have a wonderful Wednesday afternoon. Thank you.
Yeah, you're presenting on your board if you're interested. Thanks, you too. Yeah, take care.
Is it a simple way of using
It was good.
I'll actually, I mean, I get a chance to share it, but it's very. My manager support me because she do her work, and I hope to. I don't know how she's doing. Right.
Thank you. Great job. Okay.